Forget frequently asked questions.
Common sense, common knowledge, or Google.
How about advice from a real genius? 95% of people in any profession are good enough to be qualified and licensed. 5%
Go above and beyond.
they become very good at what they do, but only
0.1%
are real geniuses. Richard Jacobs has made it his life's mission to find them for you. He hunts down and interviews geniuses in every field: sleep science, cancer, stem cells, ketogenic diets, and more. Here come the geniuses. This is the Finding Genius Podcast
with Richard Jacobs.
Hello, this is Richard Jacobs with the Finding Genius Podcast. I have Keia Sanderson. She's an MD, assistant professor of medicine as well. She focuses on chronic kidney disease. I guess they call it CKD and dialysis. So, Keia, thanks for coming.
Yeah, glad to be here and to talk to you today.
So is your work research, or is it clinical, or is it teaching, or a mixture?
Yeah, it's a mixture. So I take care of specifically children who have kidney disease, and that encompasses children who have mild kidney disease, children who have severe kidney disease and are on dialysis, and children who have received kidney transplants. And in addition to that, I am a clinician researcher who is focused on kidney outcomes, in particular on children with complex medical histories, in particular children that have been born prematurely. And then I do some teaching here or there with our medical students. So it's the best of all the worlds for me.
So, yeah, I thought kidney disease was reserved for, older people, but under what circumstances do kids get it?
Right. I will say that kidney disease in children is rare, but it does occur. And the instances that it does occur are often what we would call congenital, so things that children are born with. So abnormally developed kidneys, abnormal developments in the urinary tract, so even beyond the kidneys, so the ureter and the bladder, all of those abnormalities can contribute to kidney disease. So that's the most common cause. Now, there are some children who have kidney disease because they acquired a medical condition such as, for example, lupus. But the overwhelming majority of my patients, unfortunately, have kidney disease because of something they were born with.
Oh, so what are some examples? Like, how does kidney disease manifest in kids versus adults? What happens to them that's different?
Right, and this is part of where my research arises from. The challenge with kidney disease in adults and in children is that oftentimes it's asymptomatic until the later stages of the disease process, and oftentimes because it's asymptomatic until the later disease stages, we're meeting children when they have maybe more severe disease that is often irreversible. The symptoms that children can have are elevated blood pressure, and sometimes that symptom, so for example, chest pain or headaches, those are often later in the stages of high blood pressure. So that can be one challenge. And then other symptoms can be swelling, and because of that swelling, shortness of breath, difficulty breathing, and as you would imagine, it requires quite a bit of swelling for someone to get to that point, which is why, unfortunately, we do meet some of our patients, some of our children in the later stages of their disease.
What age, so we're just talking about kids, is anyone born with CKD or born with these kidney problems or high blood pressure, or is it only after they're a few years old? Like, how does it manifest?
Yeah, that's a great question. So there is a wide spectrum. Yes, there are infants that we take care of that I personally take care of that have kidney disease on the first day of life. So they are born with a significant abnormality in their kidneys that has led to kidney failure on day of life 1. There are some children who move throughout their childhood and they're very healthy and experience then decompensation and kidney disease at any point during their childhood. And a lot of that depends upon the severity of the congenital or the kidney abnormality that they are born with, how severe it is. And then also, I mentioned acquired diseases. So it also depends upon the timing at which a child develops one of those autoimmune diseases. And I would say that the autoimmune diseases that contribute to kidney disease tend to be more common in adolescence. So that's the spectrum that we often see at any time during childhood. We're seeing expression of kidney disease, unfortunately.
Well, again, I would think it'll be very different because in a child, the kidneys are not beaten down by years and years of bad diet or other problems. So I would think they're much more resilient. And so maybe it opens up a lot more treatments for them or different kinds of treatment.
Yeah, so you're right. Children are healthy. They have healthier hearts. And you're right. There is a lot to be said for being exposed to high blood pressure for 20 years, like an adult may be in comparison to a child who's 5 or 6 years of age. And so, yes, you're right. The beautiful thing about my job is that children are resilient. And we see children who sometimes are very sick in the hospital do really well as things settle and out, as treatments have been employed. But sometimes, based upon what kind of kidney condition you are born with and how severe it is at the onset of life, it can really make the manifestation of disease quite variable. In terms of treatments, so unfortunately, there are not a lot of great treatments for kidney disease that you are born with. So whereas, for example, you were to have an infection, there are antibiotics that can treat that infection and lead to resolution. When you are born with what we call a congenital anomaly, so that means your kidney is not the proper size, does not have the proper structure, or does not have enough of the functional cells that you need for your body to be maintained in homeostasis. And those children, unfortunately, there's no medicines that make that better. What we can do is treat blood pressure, because we know in research that if we control your blood pressure, that we will delay progression to kidney failure and the need for dialysis. There are medications that we can use to help your blood counts, because as it turns out, your kidneys to help regulate your red blood cells in your body. There are medications that we can use to help regulate the salts in your body, your phosphorus, your calcium. These are all things that are also regulated by your kidney and can become abnormal if you have abnormal kidney development. But these are not actually treating the underlying condition, which is an anomaly of your kidney. And so, unfortunately, beyond treating the blood pressure, beyond treating some of the other sequelae of having kidney disease, the options are dialysis when children have kidney failure. And ultimately, our goal is to get children to kidney transplant if their kidney disease is severe enough.
It sounds like you're saying some of them are born with, I guess we have, 1 million nephrons when we're born typically? And
roughly.
So a kid that has not enough, how many do they have?
Yeah, so we have research that tells us it's quite variable. So I live in the research land of looking at kidney outcomes after preterm birth. We know that your nephrons, so these are the functional units of your kidney, the cells that are needed to help your kidney function, are developed primarily in the second and third trimester. And so if you are born before you have completed development of your kidneys, then you are born with fewer numbers of kidneys. Similarly, children who have an anomaly that developed in their kidney, even if they are born at term, meaning at 40 weeks gestation, they will often have fewer nephrons. And so because of that, the remaining nephrons are doing the workload of maybe 2 or 3. And the result of that is that they essentially are overworked, and they, over time, become diseased themselves. So they burn out. And there's many studies that show there can be variation, but sometimes children are born with 50% fewer nephrons than what they should have. And if that's the case, then they're more likely to express kidney disease earlier, as opposed to a child who may have some abnormality in their kidney development or may have been born a little bit later in the preterm period and they have more nephrons, then I might expect their kidney disease to happen later in childhood or hopefully maybe, later into adulthood.
Is there any, are both kidneys typically affected equally when someone has a problem when they're a kid, or is there an unequal effect? And if so, is it left or right or?
Sure, that's a great question. It depends. So there are some children who are born with a defect in just one kidney. And as you would imagine, so the other kidney is normal, and many of those children do quite well. So they function as one would if they had a single kidney. And so maybe there's a higher risk for high blood pressure in that scenario, because you do have fewer nephrons in total. You don't have 2 million. Now you're working with 1 million, but your risk for severe kidney disease is much lower. Then there are some children who have genetic defects. So these are things that just mutations that just occurred spontaneously in the development of the child that has led to abnormalities in both kidneys. And so again, this is one of those areas where there can be quite a bit of variation depending upon the developmental abnormality or the programming that has happened at the genetic level.
Is there any particular kidney issue that kids predominantly have more than others?
Yeah, the most common is, and this is among 70% of our children, have what we call a congenital anomaly of the kidney and urinary tract, or CACUT. And that means it's an umbrella term for a variety of genetic abnormalities, developmental abnormalities that have ultimately led to kidneys that are smaller in size than they should be, kidneys that are cystic, and so they have cysts where normal healthy kidney tissue should be. It encompasses a large group of developmental abnormalities of the kidney. So there's not one specific developmental abnormality that sticks out or that leads the way, but ultimately CACUT means that there was a programming issue in the development of your kidney that has led to abnormal nephron number and abnormal nephron morphology. So they're not normal shaped or sized, and that contributes to greater dysfunction in your kidneys after birth and kidney disease that sort of progresses over time. I like to think about, like a factory that is supposed to have a certain amount of expected output. So there's two factories that typically do the work, and those are the two factories that we all expect to have, and those are, your two kidneys. And if you take one factory completely away, the work is still expected, and so the remaining factory just becomes overworked, trying to compensate for the load that has now been expected of it because of the loss of, the other factory, the support system.
Yeah. Is there any remodeling of the kidneys in young enough kids? When they're first born, if something happens, can the kidneys accommodate somehow?
We're not seeing that so far in our research. What we are seeing is that if you were born preterm, there is some what we call glomerulogenesis, so development of your glomeruli, which are actually the structures of your nephron. That happens in the first 30 to 40 days after birth. And we're seeing that that's a critical time where we need to be more thoughtful about the way that we manage infants who are born preterm, what medications they're receiving that can affect nephron development or glomerular development. How should we be feeding infants who are having active development of their glomeruli? So these are things that are emerging in our research world, but we have not so far seen consistently a pathway that contributes to remodeling of the kidney tissue at this point. But we're hopeful that we will find pathways, and there are certainly researchers that are exploring ways to improve what we call ex utero glomerulogenesis. So if you were born preterm, what are ways that we can help protect the last few weeks of glomerulogenesis so that you have the best chance, the best number of healthy nephrons moving forward.
If you like this podcast, please click the link in the description to subscribe and review us on iTunes.
So in normal development, when are the kidneys fully developed?
Yeah, at term. So they are fully developed at roughly 36 to 37 weeks gestation. And so,
oh, wow.
Yeah, so any infant that is born before that time, consistently, the research shows will have a fewer number of nephrons in both kidneys.
So what happens to, what decides whether, your baby is preterm, they're going to be okay kidney-wise or they're not?
Right. This is the area of research, the direction that I'm going in. The short answer is that there are a lot of factors that are playing a role in addition to preterm birth, I believe. So in addition to just the fact that if you were born preterm, you are more likely to have fewer nephrons. If you're born preterm, you're born during a period of, there's going to be some development of your kidney ex utero outside of birth. And so there are certainly medications probably contributing to decrease in nephron number. There's nutrition that probably plays a role. How we even oxygenate babies after they are born preterm has been shown to play a role in normal nephron development. And then emerging and exploding area of research is looking at acute kidney injury in neonates, so in infants that are born preterm, and the role that plays in long-term kidney health. And it turns out that actually probably compounds the risk for kidney disease even greater for infants who are born preterm or who are born with a congenital anomaly of their kidney and urinary tract. So the direction that I'm hoping to go in is to find mathematical models and ways to risk stratify infants who are born preterm or who are born with a congenital anomaly of their kidneys to help us with direction. Who needs the more advanced kidney health follow-up versus who is going to be a lower risk for kidney disease and may not require as significant follow-up from a kidney health perspective over time.
If a child has a congenital defect, is there much that can be done even if you do stratify them? What do you do for the most difficult cases?
Right. So the most difficult cases, they're regularly seeing their pediatric nephrologist. And although they may leave the neonatal intensive care unit or their newborn nursery without blood pressure medications, for example, they may not be hypertensive. We are watching them very closely for the development of hypertension because we know that if it is developing and not well controlled will lead to progression of their kidney disease to kidney failure, needing dialysis and kidney transplant. So we're watching closely for that. And we're watching for some of the other signs of progressive kidney disease that we can help to manage that are associated with more rapid progression. If you have protein in your urine, there are medications that we can use to decrease the protein in your urine. And it turns out that will slow progression to kidney disease. So children that are born with a known anomaly of their kidneys probably are going to have more close follow-up, as opposed to there are certainly children who are born preterm who have no problems with their kidneys. They, are discharged home with their family and they do wonderfully well, but, it's not clear how well and how frequently they should be followed. But we do know that there is some risk for kidney disease. So there has to be some sort of follow-up. We are trying to divine that as we speak.
Well, if you look, under a microscope at the structure of, a newborn's kidney that's developed properly versus not, or, one that's not properly developed versus an adult that is now a mess because of disease, what are the significant differences you see?
Right. So again, we've done research in that world, and what we have seen is that children who are born term and are doing well. They have normal size nephrons or glomeruli, and then they have a normal number of glomeruli, and they have normal kidney volume, because we have data that tells us this is what normal is for infants. In comparison to children who are preterm, there can be some variation, but what we typically see is fewer nephrons. The nephrons that are present, or the glomeruli that are present, are abnormally shaped, abnormally sized, and scarred. Some of them are already scarred. And in comparison to an adult who maybe has had certain diseases that lead to kidney disease and kidney failure, we will oftentimes see very similar changes in the kidney structure, meaning we'll see scarring in the glomeruli or nephrons of adult kidneys that have disease, in the same way that we would see in some of our preterm infants.
How could it happen so quickly?
Yeah.
If some scarring takes years or decades, how could it happen in weeks?
Right. That's a great question. What we think is hyperfiltration. So this is a phenomenon where, again, it's sort of back to that being overworked. Depending upon the burden of disease in the pediatric or kidney, depending upon how few nephrons you have, it often will affect the hyperfiltration or the degree of hyperfiltration in the kidney. And hyperfiltration is the word that I use to simply say that how overworked the glomeruli are. And so if you have fewer nephrons, those nephrons can very quickly become overworked, surprisingly, and then become scarred much more quickly than we would expect in comparison to what we see happening in adults, which is, a lifetime of exposure and perhaps disease contributing. The other difference is we see this in adults who we assume have 2 million nephrons, right? So their reserve, if you were born term and you made it to 30, our assumption is that you have a normal complement of nephrons, and so you have greater reserve. And so it may take quite a bit longer and quite a bit more of an exposure to disease before we start to see the changes on a microscope that we might see in a preterm infant who has quite a bit fewer nephrons at baseline. Does that make sense?
Yeah, I think so, yeah. So I guess the regulation of the nephrons and the immune system hasn't fully developed. The homeostatic drive hasn't fully developed.
Right.
I don't even know what else is happening, but I guess that all those things would allow the, very quickly the kidneys to scar and not be functional instead of it taking decades normally.
Right. It's about reserve, and there's other things. So as an infant is born, they go from an environment where they are depending upon the blood flow and the oxygenation from mother to depending upon their own lungs and their heart for oxygenation. And it takes time to get adjusted to that. And it takes preterm infants even longer. And so your kidneys are an organ that really depend upon oxygenation. Your heart and your lungs are also premature, and your kidneys are really even more dependent upon oxygenation because they are really they're still actively developing. They are particularly susceptible to injury. And I think that certainly plays a role in comparison to an adult who, again, has a normal complement of kidney functional cells and is, I'm assuming, having a normal heart and lung function at the time.
So are there any novel therapies that are out, to help kids with kidney problems?
Not yet, but they're happening in the adult world. And so that's exciting because we hope that we can soon begin looking at it in the pediatric world. So there are medications that are being used for adults that have diabetic nephropathy, so kidney disease because of diabetes, which have been shown to lead to slowing progression of kidney disease, if not making their kidney disease better. And there are recently, I think, emerging data about the use of some of these medications in in adults who don't have diabetic kidney disease. So it seems to be a promising area of research in the nephrology world, in terms of maybe finding a drug that actually helps treat and prevent progression of kidney disease. And so I'm hopeful that over time we'll be able to identify this drug as a resource for our pediatric patients, but time will tell.
Anything else that you've noticed in looking at the kidneys or seeing their function, or anything that mystifies you? I'm sure there's a lot that does.
Anything that in particular that sticks out? That's a great question. I think that the kidneys are incredibly resilient, and there's still a lot that we have to learn and a lot that we don't understand. I would say what surprises me most is that, and this is the challenge with kidney disease, is that I have taken care of some children who over time have had progression, unfortunately, of their kidney disease. And I could estimate, based upon the lab work, that their kidneys are functioning at 5 to 10% of normal. And what is amazing to me is that even though I see that on the lab work for our patients, they don't necessarily have symptoms that reflect how severe their kidney disease is. And I find that to be amazing and fortunate, because I certainly don't want any of our patients to experience symptoms or to have any difficulty functioning because of their disease. But it tells me that there's a lot that we still don't understand about the kidneys if people are able to function and go about their regular everyday lives with 5-10% of their kidney function. And so that's fascinating to me. I'm happy that our patients aren't having to struggle with symptoms of kidney disease, but I think it just it means that there is a lot that we don't understand, that will, I'm sure, be evolving over time. As we are looking into research, looking at artificial kidneys and how to optimize kidney replacement therapies. I think understanding that will help as we try to understand ways to support patients with kidney disease.
Okay. Well, very good. Keia, what's the best way for people to find out more? And if they have, God forbid, they have a child that, appears to have kidney issues, what are some resources for them?
Yeah, there's UNC Kidney Center. Our website has information and resources for our patients to look up and read about adult and kidney disease, so that you can turn to there's organizations. The National Kidney Foundation has a website that provides a lot of information for parents and for adults who have kidney disease and have questions about resources and where to go for help. And so that's a great place to go. And then I would say ultimately a great resource is your primary doctor, because they will be able to direct you to here's a great resource. Here's a nephrologist that I would recommend, or a pediatric nephrologist that I would recommend, and that I'm going to connect you with. So I would look into those places. And I do want to say that, I've talked about pediatric kidney disease in children. It is still incredibly rare, and I don't think that every parent needs to have concern particularly raised if your child is doing well and growing well. I think if you have a child who has been born preterm, I think asking questions about blood pressure and does my child need more kidney monitoring is a great question to bring up. But I also want to reassure parents that it's still incredibly rare, in the magnitude of 15 per million age-related population among children. So for the most part, children are healthy and resilient.
Okay. Well, excellent. Well, very good, Keia. Thank you for coming on the podcast. I appreciate it.
Yeah, thank you for your time.
If you like this podcast, please click the link in the description to subscribe and review us on iTunes.
You've been listening to the Finding Genius podcast with Richard Jacobs. If you like what you hear, be sure to review and subscribe to the Finding Genius podcast on iTunes or wherever you listen to podcasts. And want to be smarter than everybody else? Become a premium member at Findinggeniuspodcast.com. This podcast is for information only. No advice of any kind is being given. Any action you take or don't take as a result of listening is your sole responsibility. Consult professionals when advice is needed.